Hello and welcome to Chapter 7 in Alternate Care Systems. Chapter 7, we're going to be covering behavioral health, mental health. So we're going to skip through the learning objectives as always and get to the introduction to settings. So you see these list of 5 settings here. If you look at page 222 in the textbook, you have a description and synonyms or examples of these facilities. So be familiar with that chart. Know that a group home is also called a halfway house. Know that your inpatient psychiatric hospital is called an institution, and so on. All right, so the Community Mental Health Center is the principal setting for treating serious mental illness in the United States. These were publicly funded entities established by the Mental Health Act in 1965. This congressional legislation provided the initial funding for community mental health centers on a gradually decreasing scale over a period of years, with increased funding from county and state monies intended to replace the majority of the federal grants eventually. The community mental health system was conceived as the conduit for affordable mental health services to be provided to the public in much the same way as the state departments of health were established earlier, to provide a broadly based healthcare system to all segments of the population. Over time, this service system became increasingly focused on the more chronic segment of the mentally ill population of adults and children. The increased need for a large-scale effort to provide supportive services for this population grew out of the discovery of psychotropic medications in the late 1960s to reduce the symptoms of psychosis and disordered thinking. Although the medications were not universally successful, the majority of individuals who previously had been destined to spend their lives in mental institutions were rendered capable of living in community settings. The 1970s and the 1980s saw a major push to restore the community those patients who responded well to new medications. The process of outpatient commitment became feasible, allowing courts to place persons in need of psychiatric care in outpatient programs, with stipulations regarding that medications and maintaining scheduled psychiatric appointments. All right, so we're going to skip over to page 224 at the top. A second site for provision of mental health services is the acute care inpatient hospital. The two types of acute facilities are, number 1, short-term psychiatric crisis facilities, and number 2, traditional inpatient psychiatric hospitals, where patients who do not respond to medication can be treated for a lengthier period of time. As the effectiveness of medication continues to improve in recent years, it has become less necessary for persons with mental illness to undergo long periods of hospitalization. Often during a period of florid psychosis, they are able to access short-term acute psychiatric care that lasts 3 to 4 weeks on average. Admittance to facilities providing this care is either voluntary or involuntary, depending on the ability of the potential patient to recognize the need for treatment. Involuntary commitment is a legal process whereby individuals may be admitted to an inpatient facility even though they refuse or cannot consent to the treatment if they are legally adjudicated to be a danger to themselves or others. All right, so let's talk about our types of clients. So although services for adults and services designed for children and adolescents have some similarities, there are also some differences. As might be expected, the different stages in the life cycle of those two groups necessitate some fundamental difference in status, both legal and educational, and in life tasks. In some cases, the illness also manifests itself differently within these two groups. So our first subgroup is adults. So the two types of mental or emotional illness that adults are likely to experience are temporary emotional crisis related to traumatic events or chronic long-term mental illness. Temporary mental problems result from some traumatic event or a series of events in a person's life, such as the loss of a loved one, divorce, or bankruptcy. These emotional upheavals are manifested most often in the form of extreme depression and/or suicidal tendencies. In these cases, mental anguish and sad feelings can be clearly traced to a causal factor that triggered the crisis, and that usually can be dealt with through counseling or at times with the mood-altering medication that can aid in lifting depression. Long-term mental illness, in contrast, cannot be traced so easily to a causal fashion. Its onset is a result of chemical changes in the brain, with which the mental health profession is becoming increasingly skilled, with rapidly advancing technology at observing and describing. As yet, we are unable to say in general what causes these changes. This type of mental illness is chronic in nature, in that it often can be controlled with medication, but it cannot be cured. It receives the heaviest funding and greatest research support within the public sector based on the concept that persons with serious, persistent mental illness are those most in need of the insufficient resources available for mental health treatment. Because of the many myths surrounding this type of mental illness, persons who are afflicted prefer to use the term in describing the illness that are free of the traditional connotations that arouse pity, fear, or rejection. For this reason, they particularly dislike the use of chronic as a descriptive term. They prefer either long-term, severe, or serious as descriptors of the illness, and the persons with serious mental illness, SMI, currently being the most preferred epithet. They also favor what is known as a person-first language, such as a person with schizophrenia rather than a schizophrenic, and persons with manic depression rather than manic depression or manic depressives. Most service recipients prefer to be known as mental health service consumers, usually shortened to consumers after the context has been established, or users of mental health services. Some persons also have chosen to be recognized as psychiatric survivors, so the term consumer survivor has come into use recently. As a group, they prefer this terminology over the more traditional client or patient, except in an inpatient situation or medical relationship, as with the doctor or nurse. They believe that these latter terms connote a one-down relationship and imply dependency and inability to participate in treatment planning, as opposed to the implication of a customer relationship suggested by the term consumer and service user. The most common forms of serious mental illness are schizophrenia, clinical depression, and bipolar disorder, the latter of which has become the favored term for what has been known more widely as manic depression. Another large category encompasses persons with dual diagnosis, meaning two diagnoses. These persons may be diagnosed either as mentally ill with intellectual or developmental disability, such as mental retardation, or as mentally ill with alcohol and or chemical addiction. All right, so we're going to turn over to page 226, and we're going to start about almost halfway down that page. As indicated previously, there are two types of dually diagnosed persons within mental ill populations. Persons with developmental disabilities may become mentally ill also, in which the case they will carry a diagnosis of mental illness with mental retardation or intellectual disability. The treatment modes for this group are largely behavior shaping techniques. The chief intervention is in the administration of psychotropic medication. Because of the low functioning ability that results from retardation, persons with this dual diagnosis often have to be followed carefully to ensure that the medication is actually being taken and in the correct dosage. The other type of dual diagnosis occurs in persons with mental illness and alcohol or chemical addiction. Treatment programs for these individuals are often referred to as MICA, mental illness with chemical addiction. The type of dual diagnosis is on the rise within the mental health system. Because of the wide availability of illegal recreational drugs, many young persons in particular begin to experiment, sometimes as a way to cope with the onset of the symptoms of the mental illness. Traditionally, a battle has been waged between substance abuse services providers and mental health professionals as who should serve this group. Consequently, members of this group have been shuttled back and forth between the two providers, depending on which illness was most evident at the given time and ill served by both. Also, the treatment philosophy between the two providers is fundamentally different, further reducing the likelihood of successful outcome. So moving over to 227. In the past several years, there have been a growing trend toward melding elements of both substance abuse and mental health treatment modes designed specifically for this population. Along with the cross-training, an educational model seems to be emerging. This model eschews confrontation in favor of openness to discussion of the nature of mental illness and symptom management that incorporates knowledge about the detrimental effects of substance abuse on the efficacy of psychotropic medications. The major symptoms for these types of serious mental illnesses, as well as less common ones, are described in the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or you'll hear it called DSM-5. In the 1970s, mental health professionals and politicians began to realize the deinstitutionalization would not work without continuity of care, with particular emphasis on providing a smooth transition from inpatient to outpatient services. What was needed was a service system designed to maintain mentally ill persons outside of the hospital, and this led to the Community Support Program at the federal level, an initiative originating within the National Institute of Mental Health, the federal center at the time for research concerning mental health issues. This branch of the Institute undertook studies of what services were needed to adequately support mental ill persons and who were attempting to live life independently, and how those services could best be delivered. Concurrently, the federal funding streams for most mental health were diverted to this population of the group most in need. Now, disability benefits are provided in the form of Supplemental Security Income, SSI, for those who have not been able to establish a work history, and a Social Security disability income for those with sufficient investiture in the Social Security system to be eligible. In addition, Medicaid benefits are tied to SSI eligibility, and Medicare benefits are also available based on age or SSDI eligibility. All right, so dropping down here, federal guidelines have been set up based on criteria of physical and psychological functioning, and this is our criteria. Adults with a serious mental illness are persons age 18 and over who currently or at any time during the past year have had a diagnosable mental, behavioral, or emotional disorder of sufficient duration to meet diagnostic criteria specified within DSM-3 DSM-4 or 5 that has resulted in a functional impairment which substantially interferes with or limits one or more major life activities. So that is our definition there at the bottom of 227 carrying over to 228. So that is the guidelines set up on physical and psychological functioning. All right, so we're going to drop down to the bottom of 228. The variety of services outside of the mental health system per se indicates the necessity for a holistic approach to service provision to maximize the time period that a person may remain in the community without rehospitalization. Within the mental health setting, some consider the following options to be core services that the majority of seriously mentally ill persons are likely to need at some point in the course of their treatment. And so we've got several different things here we're going to cover. So we have diagnostic evaluation and psychiatric medication management. These services are provided by a psychiatrist, nurse practitioner, and or nurse. If medical conditions unrelated to mental illness are present, the person typically is referred to appropriate medical personnel within the community for treatment. Then we have case management as a core service. This service area provides linkage and brokerage to other services. Its primary function is to obtain access for the consumer to services both within and outside of the mental health setting. Thus, it is the glue that provides coordination of support across the continuum and mitigates fragmentation of the service delivery system. Then we have day programming. This area varies somewhat from system to system. The goal is to provide an opportunity for consumers to interact with peers as well as professional staff. Some programs offer the more traditional partial hospitalization activities described previously. Others take a more rehabilitative approach, actively preparing and encouraging the consumer to move forward toward employment in the job market or volunteer work in the community and more independent functioning outside of the mental health system. Then we have residential living. This alternative is offered to consumers whose level of functioning has been impaired to the extent that upon remediation of their psychotic symptoms, they are not able to maintain themselves initially in an independent setting. They are placed in a group home, which is sometimes referred to as a halfway house, where they typically stay for 6 months to a year and practice necessary daily living skills such as cooking, money management, and personal hygiene. And then we have our screening and evaluation as a core service. The Community Mental Health Center professional staff typically determines the need for short-term acute psychiatric care and/or recommendations to the courts for involuntary hospitalization. And then you have your after-hours crisis services. Emergency services for psychiatric crisis generally are provided on a 24-hour basis through a system of on-call personnel. When necessary, screening and evaluation for involuntary hospitalization also can be provided in this way. All right, so let's move on to our next kind of client. We are moving on to adolescents and children. Approximately 9 to 13% of children ages 9 to 17 have a serious emotional disturbance with considerable functional impairment, and 5 to 9% have a serious emotional disturbance with extreme functional impairment. As with adults having mental illness, a federal definition for younger population was developed. So here's our definition at the bottom of 229. Children with a serious emotional disturbance that are persons from birth to 18 who currently or at any time during the past year have had a diagnosable mental, behavioral, or emotional disorder of sufficient duration to meet the diagnostic criteria specified within DSM-3, 4, or 5 that resulted in functional impairment which substantially interferes with or limits the child's role of functioning in family, school, or community activities. And so we have core services dropping down on page 230 about midway, core services for our adolescents and children. So the first one is early identification and intervention. This effort necessarily crosses social services systems, so health, education, but mental health has a role to play. The earlier the problem is identified, the better is the chance for successful treatment. Sometimes, however, the problems or their seriousness may not become manifested clearly until latency age or adolescence. Identification of multi-problem families who seek mental health services regardless of the age of the child may be a first step. Then we have diagnosis and evaluation. Again, this area may include several systems. It usually includes assessment of physical health, intelligence level, and academic achievement or potential, social and behavioral functioning, family dynamics, and environmental factors such as extent of poverty and type of housing. Then we have outpatient treatment. It usually entails regularly scheduled appointments for either individual, group, and/or family therapy with a frequency based on need. And then just like in adults, you have day treatment. It provides an integration of educational and mental health services, whether established formally between agencies or not. Intensive treatment includes carefully integrated components of education, counseling, and family therapy, and typically is provided during school hours. Services may be provided in a variety of settings, from regular schools to special schools to the mental health center. This service is much like the partial hospitalization program for adults, except for the inclusion and emphasis on the educational component. And then we have our emergency services, very similar to that for adults, but it is somewhat rare for children. This service for children also may include runaway shelters and home-based services that are unique to this population. And then we have our home-based services. Other terms for this type of intervention are in-home services, family-centered services, intensive family services, and family preservation services. This category encompasses a rather wide range of services. The commonality among all of them is that they are family rather than individual-centered, and as the term implies, most of these services are delivered in the home. And then we have therapeutic foster care. This service provides treatment for troubled children within the private homes of trained families. It provides a home-like atmosphere in which to apply treatment interventions. It seems similar to traditional foster care, but the families receive special training in how to cope with the extreme emotional disturbance that led to the removal of the child from the family. This setting is considered to be the least restrictive in the continuum of alternative placements because of its capacity to duplicate a home environment most closely. And then we have therapeutic group home. This type of residential setting involves congregate care somewhat similar to that of an adult group home. Some group homes exist primarily to serve less severely disturbed children who need care of a protective nature because of abuse or neglect. These children typically need a mental health treatment component as well as the highly structured environment typical of these programs. A therapeutic group home has been defined as a single home located in the general community that serves no more than 8 children. These entities can vary greatly in staff-to-child ratio depending on severity of psychological impairment and intensity of treatment. The two distinct models of care used are the teaching family model that employs a married couple who live with the children in a family-like arrangement with relief help to provide time off, or the second, the other model employs shifts of workers who rotate to provide 24-hour care and supervision. And then last, we have our inpatient hospitalization. This setting is utilized in extreme situations. Children who demonstrate signs that they might seriously harm themselves or others are referred for hospitalization. With increasing frequency as the home-based services become more generally available, such hospital stays are of short duration, usually a matter of days or a few weeks at the most. Occasionally, however, a child's difficulties are so severe that long-term hospitalizations become the only option. This setting is also used for conducting comprehensive evaluations, particularly if the possible presence of neurological or other physiological complications may require extensive testing and observation over time. As the core services came into being, a more recent concept known as wraparound services has become the predominant method of service delivery for children and adolescents with emotional disturbance. These community-based services attempt to prevent the necessity for more restrictive levels of care. As the term wraparound suggests, this is a comprehensive array of professional services that include the child's home and/or school setting. The essential features entail individualization of services to fit the specific needs of each child and family, maximization of the family's strengths and natural support systems as resources, and attention to the cultural values of the child's family and community in the way that the services are developed and delivered. All right, so let's move on to our different types of caregivers here. And I'm not going to touch greatly on all of these, so be sure to read, through these for sure. So there are many types of professionals and educational backgrounds and requirements for caregivers within the mental health system. With only a few exceptions, the types of workers who provide both adults and children's services tend to be the same. Likewise, the types of staff found in both the inpatient and outpatient settings tend to be similar, although their actual daily duties and responsibilities may differ in the extent of structure and control provided. So our medical personnel are going to be our psychiatrists, our nurse practitioners, and our physicians. So because psychotropic medication usually is considered to be essential to maintaining stability in serious mental illness, the psychiatrist plays a central treatment role in performing diagnosis and evaluation and providing medication management. Most of the medications prescribed for the illness can have severe and in some cases fatal consequences if the levels are not monitored carefully at regular intervals. The physician's role is to oversee these matters. In most settings, a nurse assists the physician, providing follow-up care as prescribed. These duties typically include monitoring of blood work and medication levels, providing injections if the psychotropic medication is prescribed in this form, and assisting with minor side effects of the medication. Then we have our therapists. These are your psychologists, your social workers, your community counselors. They have a wide array of educational background ranging from master's level, bachelor's level social workers. Persons at the master's level or higher in social work and psychology usually are allowed to perform diagnostic and evaluation screening for mental illness. In some cases, this function is provided under supervision of a psychiatrist. In some states, psychologists have gained the authority to prescribe some drugs on a limited basis and with a physician's oversight. So historically, Psychiatrists are the only ones that could prescribe the medicines, and now in some cases psychologists can. All right, flipping over to 234, we have case managers. Case managers' credentials vary widely from state to state. Most have a bachelor's degree, but there are usually a great latitude as to the field of study. The chief responsibility of the case manager is to provide the consumer in the community with access to services across the spectrum of support services as indicated. Thus, the chief functions of this position are referral to needed services, coordination among service providers, and monitoring for escalation of psychotic symptoms. Then we have our aides and direct care workers. This group of workers goes by different appellations within the various settings where they work. Direct care workers, residential living technicians, or certified nursing aides. Their primary duties revolve around providing assistance with daily living skills to persons in the inpatient setting or in community group homes. In each of these settings, 24-hour care and supervision are typically provided. Then we have our recreation therapist. Recreation therapists are found more often in the inpatient setting than in the community health setting, unless the program is conducting a partial hospitalization component. These therapists usually are employed in the structured setting to provide an antidote for the lassitude that often accompanies the illness, especially in its acute state, and to provide activity and distraction, which generally kind of break up the psychotic symptoms. So if you can keep people busy and keep them active, then they're less likely to have the symptoms. And then you have your occupational therapist. Occupational therapists typically work in the inpatient setting. They assess patients' functioning abilities and prescribe programs designed to restore patients' capabilities to work when feasible, and they teach daily living skills that increase the likelihood of the patient's successful transition to community living. All right, so I'm going to stop here with this lecture, and I'm going to pick up the rest of the chapter in a second lecture just so this one doesn't get so long. So again, be sure to read this chapter and all the information because, again, I'm skimming and just going over the highlights. Thank you. Happy studying.